Welcome back, clinical problem solvers. Today's message is brought to you by Kind Bar. We're really happy for their sponsorship. Really, without the Kind brand, we would not be able to sustain clinical problem solvers. This is a reminder to be kind to yourselves and be kind to anyone you encounter, unless their name starts with an R and ends with an H. Can you do the math, mathematician?
I have an addendum. You've always, it's always been Reza, like Reza. So I think,
But no, we're not sponsored by Kind Bar yet, but who knows? Maybe after today's episode, we'll get our sponsorship. We are very excited today. We have a dear friend who's presenting, who ends up usually stumping us. So I'm just a little bit nervous, but then I'm not nervous because Robbie says it's okay to be stumped and be wrong. So the inner Robbie is telling me to just stay relaxed. And the case presenter is dressed up, which makes me even more nervous on how formal this is going to be. Kirtan, should we be nervous or not?
Yes, so not at all. It's a very simple and basic case. It's actually, I am since preparing for this match, so I am so busy with paperwork. So this may be the last time I come here. And from upcoming weeks, I may be, a little bit more busy. So I thought that let's dress up for today and let's see how it goes.
We appreciate you, Kirtan. Thank you for volunteering. And it's so nice to see so many of your faces. Again, Tiago, nice to see you, my friend. And Hans, I see you all the time here. It's such a pleasure to see you too, my friend. Thanks for being a CP solvers through and through. And Robbie, not bad seeing you. But anyways, let's get the whiteboard. Someone take over the whiteboard. And Kirtan, whenever you're ready, present to the mathematician and let's watch his beautiful reasoning.
All right. So the chief complaint is shortness of breath and productive cough for 2 days.
Ooh, wonderful. Maybe I can just reflect on this and just to go back to one of our origins. One of our first ever episodes was to talk about shortness of breath, and Reza has a brilliant anatomical outline of the cardiac and pulmonary causes that cause shortness of breath. And I think that's where we should be. We should be asking what cardiac or lung disease is causing this patient, recognizing that there are things outside the chest that can cause this, like hyperthyroidism, anemia, acidosis, neuromuscular weakness, so on and so forth. And the question is, what does the cough help? The cough is much more likely to originate in the lungs. And in fact, all coughs originate in the lungs. But the key question is there an extra pulmonary process that's affecting the lungs? Examples, is there a massive left atrium compressing on the bronchus causing a cough? Is there nephrogenic pulmonary edema causing a cough? Is there neuromuscular weakness causing atelectasis causing a cough? So cough tells us the lungs are involved, but doesn't tell us that the lungs are the cause. So that's where I'd be at. I'd be most worried at taking a look at the lungs, probably staying within the lungs because most lung disease is intrinsic to the lungs, but there may be extrinsic diseases like kidney, like neuromuscular, or like cardiac. All right, back to you, Kirtan. Oh, I think you're muted, my friend.
Yes, so actually I forgot to tell you in the earlier part that, in all the NEJM cases, we have a nice title and then some of the diagnosis is linked to it. So I thought of that link in today's case. So the title for today's case will be a shocking diagnosis. All right. So now for the HPI part, we have a 81-year-old male who presented with the complaints of chest heaviness, dyspnea, and productive cough since 2 days. The cough was whitish and without any blood streaks. The SARS-CoV-2 PCR was done and it was negative twice. His vitals were unstable on presentation to the emergency department with blood pressure of 80/50, heart rate of 90, and oxygen saturation of 80% on O2 mask. The respiratory examination was notable for crepitations bilaterally throughout all the lung fields. The CVS examination was clear. The HRCT was obtained, which revealed diffuse alveolar infiltrates without any evidence of pneumothorax, pleural effusion, or consolidation. The CT angiogram was done, which was negative for any evidence of pulmonary embolism, but the patient continued to be hypotensive despite administration of the fluids and inotropes. The hypotension persisted even after providing the hydrocortisone, 50 mg, 6 hourly. Antibiotics were given too because of the concern for septic shock, despite the fact that fever was not present. He then became anuric, and finally the dialysis was begun, and it was done for 10 hours. And as for the review of systems, the patient denies any fever, weight loss, night sweats, headache, or abdominal pain. And do you want me to give past medical history or should I stop?
Please stop. Kirtan, so much. I don't think we've had a 0 to 100 kilometers per hour start ever in the VMR history. But thank you for all this data. There's so much. And the question is, how do we tackle this? And I can't do it alone. Robbie, please add after I speak, because I'm really interested in your thoughts as well. It's very rare where you'll hear me say that management is more important than diagnosis, although both occur in parallel. This is one of those instances where you're just worried about the stability of the patient. And of course, the diagnosis will help treat the underlying etiology, but you have to have your management hat on right now. So where should the center of gravity be? We have all of these findings. Where should we start? Well, if someone doesn't have an adequate blood pressure, they will have a PA arrest and they will die. So my center of gravity, where I'm gonna list the other findings, is right there at the blood pressure. And Kirtan gave us a bit of a clue where he said it's a shocking diagnosis. So this patient is in shock, and then we're gonna be shocked by the final diagnosis too, I assume. So the question becomes, how do we approach hypotension? The challenge with hypotension is predicting it before actually measuring a value. What I mean by this is the mental status being normal does not rule out hypotension. You only need systolic blood pressure of around 60 millimeters of mercury to be able to mentate. Of course, lack of mentation, low blood pressure, very concerning. You can also ask about urine output. So if urine output is diminished, that can be a clue to hypotension. But ultimately, not only do you need the blood pressure cuff measured, you need a lactate level, and you need to monitor the urine output closely, because this patient likely has tissue hypoxia with this severity of hypotension. And by the way, look at the patient's age. Yes, we don't have a past med. This is a young patient. Young patients have a lot of reserve. How many times has Robbie taught us that the patient who has dementia is at risk of delirium? The patient who has CKD is at increased risk of AKI. This patient where we have no background data yet, with this vital signs, very, very concerning. So now let's approach hypotension. Oh wait, the patient's 81 or, okay. It's almost, someone's playing a joke on, it's not even April yet. So I want to back up. This patient does not have a lot of reserve. Anyways, back there might
Sorry, it was my fault.
No,
I didn't listen correctly.
But 81 years young, I like it. I'm still approaching it. Let's go. So now where the center of gravity is hypotension, I'm going to comment on the hypotension and the approach. Then I'm going to pass the mic to Robbie to pick up the loose ends and add anything else that he thinks would be a benefit. Hypotension is one of those complaints that you need to have a reflexive approach to. Meaning if they wake you up at 2:30 in the morning, you need to be able to know exactly what you're going to say and what your DDX is. When you get called by the nurse that someone is hypotensive, of course, you're going to want them to repeat the blood pressure, but you should start fluids immediately and you should go evaluate the patient. What type of fluid? Whatever fluid is available. Well, Reza, what if the patient's in cardiogenic shock? Well, go and evaluate. If they are, then they probably need inotropes, they probably need pressors, they probably need the CCU, and they probably need afterload reduction. Step one, the patient's blood pressure is low. Are they having confusion, etc.? You'll look at what their baseline blood pressure is. Everything is relative and contextual in clinical reasoning. You'll go evaluate the patient, you'll start fluid. Now you're at the bedside. Now you want to determine, is this cardiogenic? Is it hypovolemic? Is it distributed? Is it obstructive? Really, from a therapeutic perspective, raise the patient's leg. Of course, if they have a fracture, be cautious there. Raise it, hold the leg up. You have about 250 to 500 cc's of fluid there. It'll be a bolus quicker than what's going in IV at 999. That's about a liter per hour. So you raise the leg up. You touch the skin. Are they cold? If they're cold, this prioritizes cardiogenic and hypovolemic. You look at the pulse pressure. Is it narrow? Again, prioritizing low volume, low stroke volume in that left ventricle. When the pressure is really low, you can't really use the pulse pressure. And the other thing is, even with sepsis, phase 2, you can become cold. You can become cold and clamp down. But this is phase 1. So you touch the skin. So Kirtan's going to tell us, is the skin cold or not? We're going to find out, is this patient fluid responsive or not? And the first passive test is, of course, going to be an electrocardiogram, a troponin level, a comprehensive metabolic panel, a lactate level, and in this patient, an ABG as well. And now I'm going to pass the mic to Robbie to try to apply the hypotension to the rest of the data and try to prioritize based on that.
I love it.
And if this patient was 20, what he would think. I'm just joking.
This is, I love that. I think that you have lungs involved, you have the kidneys involved, but the most important involvement is the cardiovascular system and its perfusion. And so maybe I'll study the rest of it. And I'll tell you that there's something really interesting that happens in medicine, because I don't think many of us are inclined quite yet to call this a pulmonary renal syndrome, but it is. The lungs are involved and there's fluid in the lungs, and the kidneys are involved because the patient is anuric. And the question is, well, how do you study those together? How do you study pulmonary renal syndromes? The term pulmonary renal syndromes is actually a restrictive term. It tells you to only study the disease processes when there's a vasculitis in both those organs. So when there's glomerulonephritis and pulmonary capillitis. But if you study the combination of pulmonary renal syndromes, you'll come to the conclusion that the most common cause of pulmonary disease and renal disease is you have a pneumonia causing acute tubular necrosis. The other common cause is that you have nephrogenic pulmonary edema. Okay, so if you have a disease process involving your lungs and your kidneys, the most common reason is you have pneumonia causing ATN, or you have renal failure causing pulmonary edema. But if we were to take the kidney as our guiding compartment and say, okay, I'm going to assume there's intrinsic renal disease, and we use our CP solver schema to say it's either glomerular, tubular, interstitial, or vascular, what diseases within those compartments cause pulmonary disease? And within the glomerulus, there's a whole list of glomerulonephritis that we should think about. And that nephrotic syndrome, the other glomerular disease, can cause a variety of pulmonary manifestations, including a pulmonary embolism. There's no tubular disease that I can think of that can cause a pulmonary manifestation. Myeloma, amyloidosis don't affect the lung. There's a lot of interstitial diseases, things like hantavirus, leptospirosis, and a variety of granulomatous infections like TB, brucella. But the most common that we see in the United States is Legionella. Legionella has a strong propensity to causing interstitial kidney injury. Within the vascular space, there's a notorious syndrome of scleroderma renal crisis that causes devastating kidney injury and has a lot of lung manifestations. So if you're trying to be methodical about pulmonary and renal manifestations, the most common cause is a pneumonia set off ATN or the kidney set off pulmonary edema. But if you're being systematic, glomerular, tubular, interstitial, and vascular scleroderma. Interstitial, a variety of infections and autoimmune diseases. And those infections, again, are hantavirus, leptospirosis, and Legionella, and then the whole list of granulomatous infections that involve the lung and the kidney. Tubular, nothing, nada, zero. A nice break in a teaching exercise, a tubular cause of pulmonary renal. But then the glomerulus is a lot, all the glomerulonephritides, every single one of them. And then nephrotic syndrome, you can have some pulmonary manifestations, pleural effusions, for example, and venous thromboembolic disease. So I encourage you to expand your horizons for you personally about what you think about pulmonary renal, but know that when we refer to them in the literature, we're just referring to glomerulonephritis and pulmonary capillaritis. And then I think what Reza said is, how do we marry the hypotension here? I think any one of those things can cause hypotension. You can have diffuse alveolar hemorrhage causing hemorrhagic shock, which is a little bit less likely, but certainly possible. You can have a raging infection, and then scleroderma renal crisis. You can get pretty severe pulmonary hypertension. So the hypotension here is compatible with all those causes. And so the question is, I think that we have to study the nature of the hypotension, which gives us an inference. If it's hemorrhagic, it'll look different versus it's septic, it'll look different. And study the nature of the kidney involvement and the lung involvement. The easiest here, if the patient gives a little bit of urine, is to understand the renal involvement very quickly and be able to land it into, is it glomerular, tubular, interstitial, or vascular? And then we can make progress on what's causing this. But I'm sure we're going to be shocked. And to shock us more, I'll pass the mic to Kirtan.
Robbie, can I ask you a quick question?
Yeah.
Just troubleshoot. Does the refractory nature of the shock help you at all or not? I was curious what your thoughts are.
You know, my reflex thoughts are, if you're not treating the underlying cause of anything, it won't get better. So if we're treating this as distributive shock, right? We're giving the patient steroids to clamp down and pressors and fluids. So if it's cardiogenic shock, it's going to get worse. If it is hemorrhagic shock, it's going to get worse. And so for me, I'm like, okay, do we have the kind of shock wrong? And if it's refractory septic shock, I don't know if that helps me. I don't know. I don't think Legionella or leptospirosis causes refractory shock, refractory distributive shock. So for me, refractory shock is, do I have the kind of shock wrong? And here, the kind of shock we're treating for is distributive. Or is it actually an aggressive form of distributive shock? And nothing that's pulmonary renal is aggressive distributive that I can think of. So I don't know how to take that further, honestly.
Thanks so much, Robbie.
Yes, so as I told you, there are no mysteries today. You guys are almost there. So now past medical history. So the patient had total knee arthroplasty 10 years back of the right knee. The patient suffered from MCA stroke 2 years back. The patient is now able to perform the activities of daily living after undergoing physical rehabilitation. At that time, so 2 years back when he developed the stroke, he was found to have elevated BP of 134/78. So just elevated BP, no hypertension. And the BP was subsequently well controlled with the diet and exercise. Apart from that, the patient is not on any medications. The patient's family history is not significant. As for the social history, patient denies alcohol, tobacco, or illicit drug use. And very surprisingly, he is physically extremely active and regularly goes to gym even after exercise. Even after suffering from the stroke, he was regularly going to gym and swimming classes, and he does the regular exercise. As for the allergies, there are no allergies. And now for the physical examination part, as usual, the BP was not, we were not able to get the BP because the patient was so hypertensive, and this was in the emergency department. So everything was literally happening in the fast lane. We never got a chance to evaluate anything quickly. So the BP was barely palpable. The SpO2 was 84% on non-invasive ventilation. The respiratory rate was 24. As for the general examination, the patient appeared unwell and was very dyspneic. Talking about the abdominal examination, there was no evidence of tenderness, rigidity, guarding, any stigmata of intra-abdominal hemorrhage. As for the CVS examination, the S1 and S2 was normal. The rhythm was regular. The JVP was not obtained because of the extreme hypotension. We tried all the maneuvers that we could, but we are not able to see any pulses there. As for the pulmonary examination, there was evidence of crackles again throughout all the lung fields. And as for the extremities, you asked, whether there was evidence of coldness or not. So yes, there was evidence of coldness. The skin was extremely cold and clammy, all extremities, and not just fingertips. All the way up to the arms, it was extremely cold and clammy. For the neurological examination, although the patient was extremely hypotensive, but he was still alert and oriented to time, place, and person. He was not encephalopathic. And the cranial nerve examination was fine. The pupils were round, reactive, and normal. The motor strength, sensory examination was all good. Muscle bulk and tone were fine. Reflexes were good too. We checked for the Babinski sign too. So it was downgoing plantar bilaterally. And maybe I can give you labs in the next report.
Yo, Prof. Rez, I feel like I rambled a lot. You want to tackle this one?
Yes, I'd be honored. Kirtan, thanks for this information. When I look at the background data, there's not much I can do with that besides saying that he's at risk of stroke, probably has vasculopathy from just age alone and his underlying hypertension. It is noted that he had this arthroplasty, but I can't link it yet to the clinical syndrome that we framed, which is an 81-year-old gentleman, sudden onset shock and an acute respiratory distress. And note, I didn't say ARDS yet because I'm not convinced we can make that conclusion yet. Of course, when you get the ABG, the PA to FiO2 ratio is going to be less than 300, probably less than 200, maybe even less than 100. However, we don't know how the heart is functioning. So when I look at this physical exam, it basically supports everything you've said. And quite frankly, it's difficult to assess for a JVP. We don't have that here, but what we're really going to be interested in is the echocardiogram of the heart. Now, I'm not a cardiologist, despite my mom wanting me to become a cardiologist. I'm not a cardiologist, but yesterday on rounds, one of the new interns taught me like 4 things to look out for on echo. I'll try to recall as many as I remember. For the non-cardiologist, one is, how is the squeeze? Is the heart squeezing or not? If the heart is doing this, guess what? I can tell you that the heart is just not squeezing and EF is low, and this is cardiogenic shock causing pulmonary edema, leading to probably acute tubular necrosis and renal insufficiency. So the echo is going to be, the pro-BNP will be helpful, the echocardiogram will be helpful. The other thing you can look for is a pericardial effusion. I mean, if you've seen enough echoes, like that's pretty easy to determine as long as you have a good view, which of course I probably wouldn't be able to obtain that view. So is it squeezing or not? Is there an effusion or not? Is the RV larger than the LV, which tells you that the RV is blown out? And that could represent an acute pulmonary embolism. But what doesn't add up there is all of the crackles that are auscultated in the lungs. So what you're giving us is a picture of acute onset left-sided heart failure, left side, not right side. Right side can lead to crackles through volume overload and third spacing, but that takes time. So right now, if this is cardiogenic, it's left-sided. So effusion, squeeze, is the RV blown out or not? And there's a fourth one that we should be able to tell, which I'm just not remembering. 75% recall, Robbie, it's pretty good. And then when you're looking at this physical exam, I have nothing else. This patient is in shock and it's cardiogenic, hypovolemic. We'll see what the hemoglobin looks like. We'll see what the echocardiogram looks like. We'll get blood cultures. The other thing to note is like I thought about toxins as well, causing a form of shock. Now toxins, usually it's distributive. The patient is warm on exam. But that's where the dialysis is helpful as well, to see if there's a toxin on board, maybe that toxin would be removed, but with dialysis. So the DDX remains quite broad. Maybe I'm a little more concerned for cardiogenic because of your exam, Kirtan. So let's see what the echo, the BNP, the CMP, and imaging and all that stuff shows. And I like the idea of a mixed venous O2 as well to help navigate that DDX. Robbie, anything to add on the exam? Okay.
All right. Yes. So the labs are really interesting. I'm sure they will help you. So the patient's hemoglobin, WBC, and platelet count were normal. For the basic metabolic panel, the sodium was 125, the potassium was 5.5, chloride was 97, LDH was elevated at 1088 units per liter, with the upper limit of normal being 450 units per liter in our laboratory. The total CPK, that is the creatine phosphokinase, was elevated as 2639 units per liter, with upper limit of normal being 195 units per liter in our laboratory. The CKMB was obtained, and the CKMB was elevated at 257 units, with upper limit of normal being 24. Troponins were also elevated. We obtained the NT-proBNP, which was elevated at more than 35,000 picogram per ml. For the BUN part, it was 40. The creatinine was 1.5 on admission, but subsequently it increased to 2.5 within few hours. The AST was elevated at 4,808 units. The ALT was elevated at 2,928 units. The patient's CRP and ESR were normal. And I agree with the fact that you need the echocardiogram and ECG, but I have saved it for the last telecode because that is the way I have framed the case. So do you need anything else in the labs?
No, we don't. This is perfect, Kirtan. I'm just going to comment on the CK, just the CK, and I'm going to pass the mic to Robbie to comment on everything else. I just want to make this one quick teaching point about CK. Usually you should start thinking about sequela of rhabdomyolysis when the CK is 5K or more. This is where experience is important, and lab markers are not binary. They're not just positive or negative. How positive and what is the kinetics of that positivity? So here, the CK being 2,639, I'm not thinking rhabdomyoglobinuria causing renal injury. I note that CK, but it's not very high. Of course, we'll repeat it. Mike, to you, Robbie, to put it all together for us, my friend.
Oy, oy, oy. I love that pearl, by the way. It came up for us in the emergency room when we were trying to admit somebody, and their CK was 6,000, then downtrended to 4,000. So we were able to discharge them and not admit them for IV hydration just yesterday. There are two reasons you can have a systemic disorder. A systemic disorder defined as a disorder that crosses multiple organs, and it's either a problem with something, an entity, independent, that's going different places, or it's a problem in the thing that is actually everywhere in your body. And no, Gabby, it's not neurology. I know that's what your first reflex. You're like, there are nerves everywhere in this body, but you know what? Nerves don't transmit diseases to other organs. They're very generous and they're protective. But unfortunately, the cardiovascular system is not as kind. And the other reason you have a systemic disorder is not that you have a systemic disease, but you have a problem in the organ that takes everything everywhere, the heart. And Reza was suspicious of it with the physical exam, and now it's hard to ignore the compelling case for a cardiovascular disease process as evidenced by the troponin and the BNP. And the connection with the pulmonary disease and the renal disease is to call this cardiogenic shock causing acute tubular necrosis and cardiogenic pulmonary edema. Of course, that's an assumption. A patient could have cardiovascular disease with separate kidney and separate pulmonary manifestations like cardiac and renal amyloidosis as an example. But the easiest way to solve this problem is to say, what's the problem in the heart, which explains the liver, which explains the lungs and the kidney. But you're at first glance, you're like, whoa, 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 what are you doing? What about the liver? The case here is actually very strong for shock liver. Why? The differential diagnosis, I'm going to pretend to fudge the numbers a little bit and tell you that the AST is 5,000. And if you look at the Tony Brew paper, which I promised to link, but on promise that I will try to link, I might forget, tells you the differential diagnosis of AST or ALT greater than 5,000 is one of two things: acetaminophen toxicity or shock liver. And how can you tell them apart? You should talk to the patient and get the other history. But the AST being higher than the ALT is much more compatible with shock liver. So this is shock liver until proven otherwise. And so, you can lump the kidney, you can lump the lungs, and you can lump the liver into a problem with the cardiovascular system. But this isn't any old problem with the cardiovascular system. This is a disease that has taken somebody who was able to exercise and then took them to death's door in the span of days. This is hyperacute heart failure, which can occur because of a rapidly growing pericardial disease like an aggressive tumor or hemorrhage in the pericardium, which can occur because of a devastating endocardial disease like endocarditis with valve rupture, or valve ischemia, or valve failure because of an aortic dissection. But most commonly, it's because of a myocardial issue like a massive myocardial infarction or highly aggressive myocarditis like giant cell myocarditis, or the 3 T's: hyperthyroidism, thiamine deficiency, or Takotsubo. So for me, this case is all about what is going on in the heart. Is it a pericardial problem, an endocardial problem, or is it massive ischemia, myocarditis, or one of the 3 T's: Takotsubo, tamponade, or hyperthyroidism? So here, what's important to do next? You got to get a TSH. You might think empirically about giving this patient thiamine. The echo will tell you if it's endocardial, pericardial, or has features of ischemia or has features of Takotsubo's. And so I think that's where I'm at. I really want to take a look at the heart, and I think that'll be incredibly informative. You might say, whoa, 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 he's conveniently ignoring the LDH. There are two reasons for an LDH this high in someone who's critically ill. They either have massive tumor lysis, which is unlikely to develop in 2 days, or they have shock liver. Remember, the LDH comes from liver, muscle, kidney. And if your AST is that high, your LDH is going to be 1,000, no problem. So I would lump in the LDH with the liver enzymes as them all coming from massive hepatocyte necrosis. Anything to add, Prof. Rez? All right, Kirtan, back to you, my friend.
Yes, so the mystery is almost solved now. So now I will give you the imaging studies. All right, so the angiography was done and it revealed the evidence of triple vessel disease. So all three major coronary arteries were involved and there was over 80% blockage in all three of them. The echocardiography was obtained with left ventricular ejection fraction of only 20%. There was dilatation of the left side of the heart with the apex, anterior septum, and anterior wall being severely hypokinetic. So there was evidence of global LV hypokinesia. There was evidence of regional wall motion abnormalities at the rest. There was also evidence of grade 3 diastolic dysfunction. So we had systolic dysfunction, then we had diastolic dysfunction. There was mild MR and TR. The inferior vena cava was congested. The right ventricular wall was functioning normally. There was no evidence of pericardial effusion or intracardiac clot or vegetation. And lastly, for the ECG, there was evidence of elevated ST segments in lead 2, 3, V2, V3, V4, and V5. I will repeat that again. So there was elevated ST segments in lead 2, 3, V2, V3, V4, and V5. So this is all the information that I was about to give. And the next aliquot will reveal the final diagnosis.
Wow, Kirtan, thank you. The plot thickens, my friend. And Robbie, let's tackle this one together. So I think right away, if we start with the echocardiogram, we've now diagnosed cardiogenic shock. And we were suspicious for left-sided heart failure. So the question now becomes, why does this patient have acute onset left-sided heart failure? And quite frankly, you can take an anatomical approach, and Robbie already shared that schema. Think of the myocardium, think of the endocardium, the valves, think of the pericardium, and think of the rhythm. We can rule out rhythm, we can rule out pericardium, we can rule out valvular, so we're at the myocardium. So now look how narrow our frame has become. It went from shock to left-sided shock to left-sided myocardial shock. And the answer is there. So let's use the other data to see how we can get the answer. The catheterization was critical. ST elevations in shock, it's STEMI until proven otherwise. What are the STEMI mimickers is what we're asking here. What can mimic an ST elevated MI and present with shock? Not just mimic it, but mimic it and present with shock. Myocarditis and stress-induced cardiomyopathy, the so-called Takotsubo's, which is named after the octopus bag. If you look at it, there's some really cool images in NEJM, which I'm sure Kirtan has reviewed multiple times, because Kirtan doesn't miss anything in NEJM. So we're at myocarditis, stress-induced cardiomyopathy, or acute coronary syndrome. Remember, obstruction of the coronary vessels doesn't equal acute plaque rupture. So this is where the cardiologist will tell you, when we did the left heart catheterization, there was evidence of an unstable plaque, and this is acute coronary syndrome. But what I'm gathering from you, Kirtan, it seems like it was stable, high degree obstruction of the coronary vessels, but not unstable plaque. Is that a correct assumption? And one real quick pearl, once we diagnosed, not me, but someone diagnosed a STEMI just based on an AST in the hospital. The AST was up, prompted an EKG, ST elevation MI. So then we're left with myocarditis and stress-induced cardiomyopathy. By the way, the fact that the LV is dilated it's telling you that this process has been going on for some time. It didn't happen overnight like I thought it did. Why? Unlike the right ventricle, the LV is used to high pressures. It's used to high pressure. So the remodeling takes some time unless there is a subacute injury to the myocardium itself. So how does myocarditis lead to heart failure? Well, literally there's inflammation of the myocardial cells. And you can do a ratio of the CKMB to CK to see if this is in fact in myocardial in origin. I don't recall what that ratio is, but we know that troponin is elevated. We know there's myocardial cell death. Stress-induced cardiomyopathy, you can tell based on echo. So there's specific findings, and there's not just one type. There's 3 types of stress-induced cardiomyopathy. There could be apical sparing, for example. So this is when it's important to talk to the echocardiographer and say, hey, are these findings consistent with Takotsubo's? But notice this, whether this is myocarditis, whether this is Takotsubo's, that's just the beginning of the journey. The question then becomes why myocarditis? Why Takotsubo's or stress-induced cardiomyopathy? The troponin kinetics can give you some insight. Robbie taught me that in stress-induced cardiomyopathy, it's up and down, similar to plaque rupture or demand, while in myocarditis, you have continuous inflammation. So you'll see the troponins remain elevated. So Robbie, let me pass the mic to you. Based on, you might know the echo find, that's where I'm leaning towards. If it's not stress-induced cardiomyopathy, I'm at myocarditis. I'm thinking I want an MRI with of course, if the patient is stable and say right now the patient isn't, I'm thinking of MRI with gadolinium to look for delayed enhancement in Apache distribution. I'm thinking of endomyocardial biopsy. But if this is consistent with stress-induced cardiomyopathy, the echo features, then I'm going through my DDX for what led to the catecholamine surge and the sudden decompensation in heart function.
I'm right there with you, my friend. I have nothing to add. I think this is a real life dilemma that people have when there is no overt evidence of acute plaque rupture on cath. Is it because the plaque ruptured and recanalized, or is it because the patient has the other 2 diagnoses that require you to rule out acute coronary syndrome? And that's whether you have myocarditis or Takotsubo. And I think I missed it initially. One helpful clue to the presence of Takotsubo is a disappointingly low troponin. And what I mean by that is this person had a normal heart when he was exercising, and now he's in cardiogenic shock. And there's a concept of the troponin EF product. If the EF is super low, in most cases of ischemia, you expect the troponin to be very high, so the troponin EF product is maintained. But in Takotsubo's, both the EF and the troponin are actually fairly low, both elevated but fairly low. So, Kirtan, do you want to remember what was the troponin again?
Yes, so actually I don't have the exact numbers, but they were quite high. I'm sorry, I don't have the exact numbers.
Robbie, remind us, what was that called? The troponin EF product?
Yeah, the troponin EF product. And if the troponin EF product is less than 250, so you multiply the EF by the troponin. If it's less than 250, it's pretty suggestive of Takotsubo's. So, if the troponin is high here, that's unusual for Takotsubo. And so I think the question is this myocarditis? And then if it's myocarditis, the one myocarditis that does this is giant cell myocarditis. It takes somebody who was previously completely fine and makes them in this state. And so what's what's actionable? Let's just focus on the patient. What can we do? If this is giant cell myocarditis, which you can probably consider empirically treating for if the review of the cath film concludes, hey, actually, we don't think there was a plaque rupture, steroids might be life-saving for this patient. And if it's Takotsubo's, which you would gain by looking closer at the echo or getting an MRI, you would change your management. You might think about less inotropy, because inotropy makes the possibility of outflow tract obstruction worse. So here, there's a lot of things that you have to think about. If it's not ischemia, do you give this patient steroids for giant cell myocarditis? Or if it's Takotsubo's, you have to think about potentially giving more fluids, less inotropy, to combat against LV outflow tract obstruction. And the final thing I'll say is it's important in a patient who has Takotsubo's who presents with shock to think about secondary causes. And that's where my friend Tiago jumps in, because secondary causes of Takotsubo's like pheochromocytoma or hyperthyroidism are more likely in patients who present with shock. So there's a lot of work to do for this patient, but really in real life, it's happening at the expert's hands. Is this actually ischemia? And do we miss a little plaque there that we didn't see? Is there need for steroids for giant cell myocarditis, or do we have to worry about changing management for Takotsubo? Because Takotsubo cardiogenic shock is very different than the other kinds of cardiogenic shock. It's a hard real life dilemma for somebody who's this sick. That's what I got.
Yes. So now there are certain pearls about the final diagnosis. First of all, that if the patient had such massive myocardial infarction, then why the no chest pain, right? I mean, why no classical symptom? So that was the first part. We always talk about that what can cause cough. So we talk about rare causes of cough, like let's say thyroid problem can cause cough, some obstructive etiology around the trachea can cause cough, even giant cell arteritis can cause cough, right? But the thing is that in older patients, MI tends to present in atypical way, right? I mean, sometimes MI doesn't present with the pain at all. Sometimes it can present with abdominal pain. Sometimes it can present with heartburn and all sorts of things. So in our case, the patient had cough mainly because of the pulmonary edema, because it will irritate the alveoli and all the baroreceptors and chemosensitive receptors, and that will cause the cough. So that was the first part. And now, although there was no evidence of a particular coronary plaque, but we know that angiography can't determine the state of the coronary microvascular disease, right? And if we presume that the patient was relatively all right all through this much years without developing any symptom, but still ended up having more than 80% stenosis in all three arteries, it means that our body physiologically may have done anastomosis in the microvascular part, because that's what coronary microvasculature is for, right? It develops anastomosis over the time and you can't detect it on angiography. And we have to get MRI gadolinium, as you mentioned astutely, that we have to get that to see how the anastomosis is in there. So despite the fact that there was no plaque rupture, the final diagnosis thought by cardiology team was that it was indeed acute myocardial infarction, massively affecting the left ventricular wall, and that led to cardiogenic shock. And that led to cardiorenal syndrome, because we know how the heart and kidneys are related. Dysfunction of one can cause dysfunction of another part. And furthermore, if there is low cardiac output, then the flow in the hepatic arteries would go down. And furthermore, the IVC was congested. So if we are not supplying new blood to liver, and if we are not allowing the efflux of deoxygenated blood, then the heart will undergo shock liver, as you mentioned very earlier on, that it's a classic sign of shock liver. And furthermore, when we have got ischemia all over the body, then there will be massive cell necrosis. And that's why we will get elevation of LDH. So even the liver tissues are dying, even the cardiac tissue is dying, and all other tissues are also not able to function properly because of the extremely low hypotension. So that's the shock liver. So we had cardiogenic shock, then we had the shock liver. And finally, the muscle part, I really love the caveat which Rabi mentioned, that anything about 1,000, 2,000 doesn't mean that it is polymyositis, dermatomyositis, or anything like that. We need to have the context. So usually in the inflammatory myopathies, the creatine kinase is like 10 to 20 times the upper limit of normal, whereas anything below 5,000 is a little bit less worrying for us. So the thing here is that when we see the literature on acute ischemic injury to the liver, then in more than 50% of the cases, there is also evidence of myonecrosis, because when the tiny blood vessels supplying the muscles are affected, then it will lead to rhabdomyolysis. So that was the reason why our patient's creatine kinase was so high, because shock liver can be accompanied by that in almost 60 to 70% of the cases. And apart from that, unfortunately, we couldn't save the patient. We tried everything. So after doing angiography and everything, there was no evidence. I mean, there was no scope for angioplasty because 3 vessel disease was there. And given the age, we can't move for CA-BG2. So we gave aspirin, we give nitroglycerin, we give anticoagulants like heparin, we tried everything. And there was concern for giant cell myocarditis too. And that's why initially when we gave the steroids 50 mg/6 early, we later on escalated it. We give IV methylprednisolone, but still we couldn't salvage the patient. So it was a sad story. But the moral of the story is that the reason why I titled it as shocking diagnosis is that despite being totally healthy, because of this microvascular anastomosis, you can go totally fine. And then in the end, it just takes a little bit of stenosis to end everything. No matter how much anastomosis is there, you can't supply the blood to heart. And that led to the shock liver, that led to the shock muscle, if you may. And that's why the diagnosis is a shocking diagnosis. So what are your thoughts, Abhi and Reza? How can we may have improved this condition? How we may have tackled it earlier?
I just want to say, Kirtan, your understanding of like pathophysiology is inspiring. And it's such a privilege to see you explain every single abnormality through a physiologist lens. And I encourage all my learners and myself to try to explain every lab finding, not to necessarily react to it, but to paint a story for it. The only comment I want to make is that I think the purpose of this case is shock. When you're in shock, think of those 4 buckets. When you're in cardiogenic, try to localize it to the myocardium, the endocardium, the pericardium. When you're in myocardium, try to localize it to the left or the right. And then finally, know that when you have ST elevations in shock, 3 diagnoses come to mind: STEMI, myocarditis, stress-induced cardiomyopathy, and the complexity of this case requires communication with the cardiologist. I don't think anything could have been done differently. The patient got the cath. They need to use the echo findings, use the EF trope product, use the trope kinetics, maybe even an MRI with gadolinium in the stable patient to try to distinguish amongst these three causes.
I couldn't have said it better. I completely agree. I think this is a case, many cases in CP solvers, VMR, it's hard for each of us to see individually in our lives, which is so nice when we all talk about them. This is a case, I think, if you haven't seen it, you'll see it for sure. Something similar to it. I think it's humbling. And I think, it's amazing what people can walk around with and how compromised their body can be. They're on the edge of a cliff, and sometimes it takes something small to take them off the cliff. I don't think there's anything you could have done, honestly, that's different. In fact, the one thing you could not have done is to present him here today for us to learn and grow and reflect on. And so as you wish us a temporary goodbye and you focus on your other things, it's awesome that we get to learn with you in style, both learn with you dressed in style and learn with you through such a wonderful journey. Thank you so much, my friend.
Yes, I am not living anywhere. I have to stay here to keep my mind fresh. So I will be there. Maybe I may not be able to contribute to scribing and teaching as much as I would like to. So sorry to all my fellow CP Solvers team members, but I would be definitely there to learn everything.
All right, wonderful. Oh, Rafa, my favorite co-host. Take us home, please.
Oh my God, I just want to echo what everything just told us, you and Reza and everyone from the chat. Like, you're just brilliant, and it's just a privilege to learn from you. So we had a patient with shortness of breath and projective cough. When it comes to dyspnea, we have to consider brace rate, heart and lung being our priority, but we don't have to forget other less common causes, including hyperthyroidism, anxiety, acidosis, neuromuscular weakness in the setting of ALS, myasthenia gravis, or obesity. And then Rabbi reminded us that when it comes to cough, we have it's localized to the lung, but we have to look at the cause, like is it intrinsic or is it extrinsic? For example, a cardiac cause, like a heart failure leading to pulmonary edema. And then when it comes to shock, which was the center of this case, a shocking diagnosis, we saw that shock is a life-threatening fall in blood pressure with poor tissue perfusion. And then Reza reminded to search for clues, for example, the lactate level, the urine output, the tachycardia that could be seen as a reaction to the shock. So we have to repeat the blood pressure, give fluids, assess the needs for vasoconstrictors, inotropes, and then Reza reminded us that always to raise the legs because it could increase the venous return with increased preloads, and that could lead to a higher cardiac output. And then comes the question, which is the type of shock that is at play? Is it distributive, for example, due to peripheral vasodilation, the setting of sepsis and anaphylaxis, or cardiogenic cause, for example, decreased cardiac output due to MI, or obstructive, there's an obstruction leading to decreased cardiac output, for example, in the setting of pulmonary embolism, cardiac tamponade, or it's hypovolemic, like in the setting of hemorrhage, burns, or dehydration. And then another clue that as a reminder us to look at the physical exam is the skin. So if it's cold, clammy, due to high systemic vascular resistance, we have to think about hypovolemic, cardiogenic, and obstructive shock. But if it's warm and dry with low systemic vascular resistance, we have to think about distributive shocks. And then Rabbi brilliantly taught us about pulmonary pulmonary renal associations. For example, pneumonia could lead to acute tubular necrosis or renal failure leading to pulmonary edema. But then we have to search for another etiologies as well. For example, nephrotic syndrome leading to pulmonary embolism because there are loss of HA3 in the urine, leading to hypercoagulability, but also pleural refusion. And then when it comes to the interstitial of the kidney, we have to think about infectious causes like hantavirus, leptospirosis, TB, Legionella. The vessels, we have to think about sclerodermal renal crisis leading to severe pulmonary hypertension. And there's this spiral that if the CK is less than 5,000, we check again. And if it's low, we can rule out rhabdomyolysis. It's less likely. And then the center of this case was actually cardiogenic shock. And that could explain the pulmonary edema, the ATM, the shock liver. What led you to think about the shock liver was the AST, LLT higher than 1,000 and the LDH also higher than 1,000. And there are many causes that could lead to cardiogenic shock, including acute MI, heart failure, valvular dysfunction, arrhythmia. And then finally, the spiral that we can actually multiply the troponin by the ejection fraction. And if it's less than 250, it's suggestive of toxic tubule. And because they're in that setting of the disease, there is low troponin levels. So thank you, everyone. This was such a very nice case and I hope everyone enjoyed it.